great pleasure to welcome you all via Zoom to this third in a series of basic science virtual symposia developed by the American Neurogastroenterology and Motility Society. And this session is entitled Basic Concepts in Neurogastroenterology. Can functional gastrointestinal disorders be classified by mechanisms? Are we there yet? My name is Beverly Greenwood van Meerveld, and I'm the immediate past president of the ANMS. And it's great to see so many participants. And for those of you who are not members of ANMS, please consider joining the society. It's great for your professional career growth and has many benefits, including access to doc matter. So visit the ANMS website for details. So the goal of these basic science virtual symposia is to keep you up to date with the latest research in the field of neurogastroenterology and motility, until a time comes when we can all meet again in person at our annual meeting, which will hopefully be in Boston in August 2021. So on behalf of all the members of the ANMS, I'd like to thank each of our speakers today for their participation in this virtual session. And it's now my great pleasure to introduce today's moderator, Dr. Lin Chang. Lin Chang is a professor of medicine and vice chief of the Vachi and Tamar Manukian Division of Digestive Diseases at the David Geffen School of Medicine at UCLA. Dr. Chang also serves as the co-director of the G. Oppenheimer Center for Neurobiology of Stress and Resilience at UCLA. She also has clinical expertise in functional gastrointestinal disorders, focusing on brain-gut interactions in IBS. Dr. Chang is previously served in a capacity as president of the ANMS and is currently at the Clinical Research Council of the AGA Governing Board and a member of the Rome Foundation Board of Directors. Thank you, Dr. Chang. We're really looking forward to this virtual session today.
Thank you so much, Beverly. I've been honored to been asked to moderate this outstanding session, symposium with three wonderful speakers. Our first speaker today is Dr. Michael Camilleri. He's professor of medicine, pharmacology, and physiology at Mayo Clinic, Rochester, Minnesota. He has also served as past president, served as president of the ANMS and also was president of the AGA. And today he's going to talk about edging closer to personalized medicine by functional GI disorders by understanding the pathogenic mechanisms for diagnosis and treatment.
Thank you, Lynn. And thank you, Beverly, for making this possible. And welcome to all. And I will get on to this. So thanks for announcing the title as well, Lynn. So I just want to show you the last time I was out of Rochester, Minnesota, I was actually in Anfield in Liverpool in England, watching a soccer match between Liverpool and Bournemouth. And I love this gate coming into the soccer stadium because it shows this: you'll never walk alone. And for those of us who look after patients with functional gastrointestinal diseases, our motto should also be to our patients, you'll never walk alone. So let's see, how are we edging closer to making it possible to apply personalized medicine? Incidentally, a lot of my comments, which you'll be hearing about, are published in a paper in Gut, and you see the PMID number at the end of that slide. So what I propose to do is to deal, first of all, with functional lower gastrointestinal symptoms to identify actionable biomarkers for organic etiology. And I'm going to focus on pelvic floor dyssynergia. I'm going to remind you to look at the abdominal pelvic imaging and to carefully examine the results of an anal rectal manometry and balloon expulsion test. I'll then spend some time talking about bile acid diarrhea, illustrate how colonic transit measurements can be helpful, and then show how the organic pathogenesis can also be applied for the selection of patients for special diets. And I shall focus on gluten and sucrose. And then finally, I'll talk briefly about biomarkers in disorders of upper gastrointestinal function, emptying, accommodation, and satiation. So let's start with the very common problem of constipation. a very large review of the literature by Justin Brandler, who's now a GI fellow at the University of Michigan, and myself, looked at the data and the literature on almost 6,000 patients, and another series that separated out the patients with rectal evacuation disorder according to whether they also had slow transit constipation. But basically, about a third of patients who have constipation presenting to us in gastroenterology will have evidence of a rectal evacuation disorder. So is this just in referral gastroenterology practice? And the answer to that question is no, because Nick Talley, in this landmark article, which was published many years ago, had shown that about 26% of patients with in the community have some form of constipation, and among these about 42% had symptoms based on questionnaires using the Tally validated questionnaires, symptoms of functional constipation and outlet delay. And this, therefore, is a consistent finding of about a third of patients, whether that's in the community or in referral practice, have evidence of a rectal evacuation disorder. I want to remind you that if your patient has had a plain abdominal radiograph or indeed a CT scan of the abdomen and pelvis, look at those x-rays, because you can often identify the presence of a gas shadow, our dark black gas bubble in the pelvis just above the level of the pelvic floor, which you can also see on transaxial images. And this is a very good screening approach to identify patients with rectal evacuation disorders. This is also associated with retention of isotope in the left side of the colon at 24 and 48 hours. And also you can see that quantitative information shows that if the surface area of that rectum containing gas or gas and stool is greater than 9 square centimeters, there's about a 70% likelihood, even before you've done your anal rectal manometry, that the patient actually has a rectal evacuation disorder. You need to train your finger. The digital rectal examination is still a very important part of the examination. And if you train your right index finger for several years, as I have, you can identify, based on your assessment of decreased normal or increased tone or squeeze pressures, the same result as would be obtained on anal rectal manometry. One final point on this is that the balloon expulsion test, often people use a 60-second threshold for identifying abnormal rectal evacuation. What we actually have found in a series of more than 400 patients examined by a single gastroenterologist, that is myself, that a cutoff of the time for expulsion of the balloon of 22 seconds has the best sensitivity and specificity and negative predictive value. So if your patient can pass the balloon in less than 20 seconds, the likelihood of a rectal evacuation is extremely low. The fellows think that my right index finger should now be renamed, but we'll go on. So the evacuation disorder can sometimes present a picture on transit measurements. This is scintigraphy, but it could also be identified, for instance, with radiopaque markers, showing that in evacuation disorder, the isotope or the markers at 48 or 72 hours are predominantly in the descending colon, but the ascending colon is empty. In contrast, in patients with slow transit constipation, you can see the ascending and transverse colon contains a large amount of the residue, suggesting that you can use this non-invasive objective measurement to identify slow transit constipation. This is an interesting story. A patient told me, I wake up with a very flat abdomen, and as the day goes on, my abdomen becomes more and more distended and I feel bloated. Miracles must happen while we're asleep. So I remembered this beautiful paper by Peter Warwell and Leslie Houghton using what Peter Warwell calls the bloatometer, where the circumference of the abdomen is measured. And as you can see that after lunch, the circumference, the girth increases. After the evening meal, it increases again. And then when you fall asleep, the diameter and the circumference of the abdomen drops. And this is then followed by breakfast, and it goes up again. And what is really quite interesting as well is that the the work from Alice and Malcolm John Kello showed that the distension of the abdomen is often associated with a prolonged time for balloon expulsion. And that is that prolonged balloon expulsion, therefore, is a predictor of abdominal distension and bloating. Therefore, we have to keep in mind that some of the abdominal symptoms like bloating distension may also be secondary to evacuation disorders. Let's move on to diarrhea. You all know that patients with ileal disease can have diarrhea due to Crohn's disease, but we're going to focus on type 2 bile acid malabsorption, where there's a problem with the handling of bile acids and the reabsorption by the terminal ileal enterocytes. Epidemiological studies from all over the world using diverse methods to measure have shown that 25 to 50% of patients with functional diarrhea have evidence of bile acid malabsorption. And this is the commonest method used in some countries, like in European countries. That's the 75 CCAT retention at 7 days. And one can see that the retention at 7 days is about 50% normal, whereas here you can see that at 7 days in a patient with bile acid diarrhea, there are very few counts from selenomethionine CCAT compared to the baseline. Less than 5% is retained. That's severe bile acid diarrhea. That test is not available in many countries, including the United States, and so we've been involved in validating stool tests. And here we see the 3 primary diagnostic criteria: elevated total fecal bile acid, elevated primary fecal bile acids, or a combination of the two. More than 1,000 micromoles per 48 hours, more than 4% primary bile acids in that 48-hour stool collection. This is done the same way as when you do a 48-hour stool fat, and we often clinically measure both bile acids and fat in these patients with chronic diarrhea. More recently, this has just been published in Gastroenterology, we've actually extended those studies so that with a fasting serum C4 measurement and the bile acid content of a single stool sample, we're able to identify those patients who have a stool frequency greater than 3 per day, stool consistency, Bristol Stool Form Scale greater than 5.5, and also the presence of bile acid diarrhea based on the gold standard of the 48-hour stool collection. So as you can see, the area under the curve is really quite good in terms of using this as a diagnostic test, perhaps as a screening first test in patients with suspected bile acid diarrhea. Now, why is it important to actually diagnose the bile acid diarrhea? This is illustrated by work which we have done here at Mayo Clinic, published this year, showing that if you have a diagnosis of bile acid diarrhea and you give the patient bile acid sequestrants, there's about a 75% likelihood that the patient's going to respond. If, on the other hand, you just give an empiric trial of patients with chronic functional diarrhea, and you empirically, without measuring bile acids, give them a bile acid sequestrant, the response rate is going to be closer to about 25 or 30%. Finally, I want to mention a couple of points about selecting patients for special diets. And here is data showing that if you're going to select the patients to reduce gluten in the diet, and we see so many patients now who have stopped gluten in the diet, you can see that it's the patients who are HLA DQ2, DQ8 positive who have the best response, illustrated, for example, by these closed symbols in patients who were given a gluten-free diet. So if you're thinking of doing a gluten withdrawal, think about estimating or haplotyping the HLA-DQ haplotype. Finally, from a diet standpoint, disaccharide intolerance. Remember, lactase deficiency, extremely high prevalence related to ethnicity and race. But also more recently, work by Mauro D'Amato and also Bill Che and other colleagues have illustrated the importance of, in a few patients, the importance of congenital sucrase isomaltase deficiency. Basically, there are a number of polymorphisms. The one that's really impressive, as I look at the data, is this polymorphism, Val15Phe, which is associated with an increased stool number, and it may also have an effect on who is actually going to respond to a low FODMAP diet. This was illustrated by a recent letter to the editor of Gut by Bilche and Mauro D'Amato and others. So you can see that the patients who have this carrier of these mutations do not appear to respond to a low FODMAP diet. Let's move on now to consider upper GI tract. I think it's important to remember the utility of 4-hour gastric emptying study. These are normal values from our gastric emptying study here at Mayo Clinic. We tend to use a higher fat content in the meals, but we have established normal values in more than 300 people. And the important thing is that there is a relationship between the improvement in upper gastrointestinal symptoms and the improvement of gastric emptying T-half on a systematic review and meta-analysis in response to treatment for gastroparesis. So if you measure it correctly, that is for 4 hours and using a solid meal, you will find there is a good correlation between improvement in gastric emptying and improvement in GI symptoms. We also see here that among patients with upper GI symptoms that could be functional gastroduodenal symptoms like functional dyspepsia or gastroparesis, you'll see that about a quarter have abnormal gastric emptying alone, a quarter have abnormal gastric accommodation alone measured in our center using SPECT, a quarter have both, and a quarter have neither. So there are pharmacological approaches that we can use for both delayed gastric emptying and impaired gastric accommodation. If you don't have SPECT or MRI, you could use something that Jan Tak popularized, which is a nutrient drink test. And when we look at this part of the curve, you'll see a good correlation between the amount of calories that are ingested and the amount of accommodation of the stomach measured by Jan Tak's group by Barostat. You see the linear relationship. So if you don't have a way to actually measure by imaging, you can certainly also do a nutrient drink test. And if the result is less than 750 kilocalories, then we would say that that patient is likely to have impaired gastric accommodation. Just very briefly to say that for all of these tests that I've mentioned, we have very robust normal values as published in the literature, and I'm not going to take you through all of these details. These are in that paper that I mentioned earlier, showing that there are actionable biomarkers for both lower and upper functional gastrointestinal disorders, and I've explained some of these in the past few minutes. So this is a summary slide that tells you what we've talked about: accommodation, transit, anorectal manometry, bile acid measurements, and gastric emptying. And I want to just give credit to my mentors, Juan Malagelada and may he rest in peace, Sid Phillips, who put me on the track to try to understand how to take what we learn in the lab in the morning and apply it in the clinic in the afternoon. So thank you again for your attention. I'd be very happy to answer questions later in the Q&A period. Have a good afternoon.
Thank you so much, Michael. It's great to see that there's more actionable biomarkers than I think we ever thought in the past, and hopefully we'll have more in the future. Be sure to just enter any questions in the Q&A. So we're going to move to the next talk, and it's by Dr. Beate Niesler. She's a professor at the University of Heidelberg, and she heads a research group there at the Institute of Human Genetics in Heidelberg, Germany. Her major focus is on the genetics of neurogastroenterology and neurodevelopmental disorders, as well as molecular and cell biology, and she has a long-standing interest in the serotonergic system. So the title of her talk is Disease-Oriented Genome Networks, Role of Serotonin Receptor Genes and Gene Mutations and Polymorphisms in Other Genes in the Etiology of GI Disorders.
So thank you very much, Lynn, for this kind introduction. And yeah, thank you for giving me the opportunity to guide you through the serotonergic system and its relevance in functional GI disorders. And so Lynn Dr. Chang already mentioned it, that my background is human genetics, and just a small overview slide for you, guiding you through my talk of today. So I will first introduce relevant knowledge, then report on some studies and give you a summary and outlook slide on that. So first of all, let me explain that I will focus mainly on IBS because most of what we know so far has been gained in studies with IBS patients, and where data is available, I will also report on other data. And just to remind you that in functional GI disorders, we are dealing with multiple layers of complexity that contribute to its pathogenesis. And these are extrinsic factors in combination with intrinsic factors, among them gut microbiota, but also our individual genetic background, shaping different cues in the gut as well as the brain, and also influencing the gut-brain axis as well as the stress axis and visceral perception. And in the end of the day, manifesting as either functional GI disorders and or comorbid conditions. And one of the key players shaping this is serotonin, or 5-hydroxytryptamine, 5-HT in short. And I included here a tag pathway, which looks quite busy, but I'd like to draw your attention on some of the key molecules here. Tryptophan hydroxylase, which is the rate-limiting enzyme involved in 5-HT synthesis, which once released exerts its function via a variety of 5-HT receptors. We know 7 families of them, which are all G protein coupled, except for the 5-HT3 receptor, which is the only ligand-gated ion channel. And once released, in order not to overexcite the system, the 5-HT has to be reuptaken, and this is done by the serotonin transporter. So what about serotonin in the GI tract? So more than 90% of 5-HT is synthesized by EC cells, which upon an external trigger, and since recently we know also microbiome metabolites can induce that, TPH after synthesis, 5-HT is released and exerts its function to downstream receptors. And the serotonergic system is involved in the regulation of key functions of the GI tract, as well as the immune system, pain mediation, and anxiety control. And these are all well known to also play a role if disturbed in functional GI disorders. And I already mentioned it, the function is mediated via 7 receptor classes. And what I found quite intriguing from the very beginning is that we have actually medication, drugs who help some of the patients, but so far we do not really know which ones to give which patient, which in the end of the day currently leads more or less to IBS treatment on a trial and error basis. And better understanding what's going on a molecular level really, hopefully in the future, gives us the opportunity to stratify patients. So what kind of pathological findings do we have in the 5-HT system in the gut? So we know that TPH1 levels have been found to be different in IBS patients compared to controls. Furthermore, we also found serotonin transporter levels reduced in IBS on protein level, and furthermore also in turn the mucosal 5-HT content increased. And this has been found in tissue of patients in the colon, but further on also in serum of patients, and also 5-HT levels, and also the main metabolite 5-HIAA have been found to be changed in IBS. And this was mainly in IBS-D so far. So further on, there is one study on functional dyspepsia where in the duodenum biopsies have been investigated. And also here they found changes in TPH1 and the serotonin transporter gene SLC6A4, as well as the serotonin receptors HTR7 and HTR3E. So now let's move on to the genetic findings, the molecular findings in the 5-HT system in the blood. So there is one nice study where TPH1 polymorphisms were found to associate with IBS-D, and in particular with bowel habit subtypes like diarrhea and watery stool. And further on, another study found a TPH1 promoter SNP to be differentially regulated by a transcription factor called early growth response factor, and to also correlate with different IBS bowel habits, and they found it associated with diarrheic IBS. The serotonin transporter gene SLC6A4 has been most extensively analyzed in IBS, and this one was earlier known to drive the expression differently and had initially been found to be associated with anxiety and depression. And this functional polymorphism, which comes in two flavors, leads to, in case of the S allele, to decrease SERT levels, and in turn to increase 5-HT levels. And we know that this SERT-P1S allele, which is functional, increases the vulnerability to the impact of life stress on psychological and somatic health. So it's a gene environment effect.
Beate, you were muted. You just need to unmute. Somehow it got muted. Or Stephanie, maybe you can unmute her. Beate, do you see?
Now it's, sorry,
okay,
can you hear me now?
Yes. Great.
I'm sorry, I don't know what happened here. Sorry. So actually, and this polymorphism, the SL polymorphism, was significantly correlated with IBS-C in a recent meta-analysis, and it earlier had been also analyzed in functional dyspepsia, but with mainly negative findings. So due to this controversial situation, and because it became obvious that there is another promoter driving the expression of SERT, mainly in the GI tract, my team analyzed a new promoter region, the P2 promoter region, for its relevance in IBS. And to make a long story short, we found a haplotype, so a combination of SNPs associated with IBS-C in female patients. And by analyzing this promoter region in 4 different cell lines, we could find a functional effect that it drives the expression of the SERT gene differently. And by analyzing the SNP in a large meta-analysis, we could prove it and replicate it in IBS-C in female, and going further on, performing correlation analysis regarding the genotype presence and expression levels. Could also prove in small intestinal tissue that it correlates with differential expression, and that also the respective genotype correlates with stool form. And performing comparative promoter analysis found out that the polymorphic haplotype harbors transcription factor binding sites of transcription factors which have been implicated in other GI disorders, including IBD before. Furthermore, there is another study which found differential expression of microRNA 24, which they could prove also to differentially, to fine-tune expression again of the SERT gene, SLC6A4. And in turn, the levels of this gene were found to be reduced. And in gene reporter assays, they could also prove its differential expression function. Further on, my team has a long-standing interest in 5-HT3 receptor genes. And we found 4 SNPs in this receptor family to be associated with IBS, but also other conditions which we know are seen comorbidly with IBS, like psychiatric disorders or pain disorders, and all of them have been proven to be functional. So the HGR3A receptor polymorphism, for example, resides in the untranslated region and drives the expression differently, leading to a higher expression. And this one has earlier been found to be associated also with anxiety and depression and differential amygdala activity. Furthermore, two coding SNPs in the C and B subunit in the coding region lead to different 5-HT efficacy. Here you can see functional data of the C subunit of the polymorphic one, and of the B subunit mutation leading also to higher channel conductance. And what was quite interesting as well was a mutation in the 3E subunit, which hits a microRNA binding site and thereby impairs the fine-tuning of receptor expression, leading to higher expression. And this was found to be associated with IBS-D in females. And colleagues from China could prove this even also in tissue of patients, showing that if the variant is present, they found higher 5-HT3E receptor expression in colon tissue, as you can nicely see here. So furthermore, we tried to replicate those 4 SNPs, and all but the HGR3E SNP replicated, none of them but the HGR3E SNP replicated in IBS-D in female patients in this case. In the meta-analysis, we analyzed more than 12,000 people from 12 cohorts from different countries all over the world, and the HGR3A, B, and C did not hold true, so we couldn't find an association anymore running the meta-analysis, but this one replicated nicely with a quite robust odds ratio of nearly 1.6, which is quite high for a complex disorder. So furthermore, we wanted to get an idea about differential expression of this particular subunit gene, and we analyzed 4 gastrointestinal biopsies from 4 gastrointestinal regions, from the jejunum, the ileum, and the colon, where we could not see any differences, but we saw differential expression in the sigma of the patients, which we could then attribute, which was driven by diarrheic IBS. So the 3E subunit we found to be differentially expressed in IBS-D patients as well. We furthermore also analyzed the 5-HT4 receptor gene, and also here, to make a long story short, we sequenced the whole gene and we found again a SNP residing in the 3' untranslated region, which also hits a microRNA binding site motif, which we could then in the end, so for a microRNA family, microRNA 16, this is this microRNA family, and microRNA 103 binding is impaired if the SNP is present, and this one could be found to be associated with IBS-D. And if the binding site is disturbed by the SNP, it again leads to higher gene expression. And then further on, moving on, performing analysis of microRNA expression in a cohort of IBS-D patients, we found also, in addition, differential expression of microRNA 16 and microRNA 103, which nicely correlated then also with bowel movements and with stool form, that we can conclude that if either the SNP is present or the microRNA 16 or 103 are downregulated and or impaired, this seems to lead to higher receptor expression, which in the end may manifest in increased secretion and peristalsis, contributing to IBS-D symptoms seen in these patients. Recently, there was another nice study published where for the first time the HGR7 gene was found to be associated with irritable bowel syndrome. And in this study, colleagues found microRNA 29 levels to be increased, and in turn, the putative target 5-HT7 receptor gene, the HGR7 gene, to be downregulated. And they also could probe this. So this was downregulated not only on mRNA, but also on protein level. And going further on, they could even prove this then in reporter assays, confirming that this microRNA really regulates the HGR7 gene. So in summary, we can say that in terms of the 5-HT system, we found differential expression of key players of this system in GI tissues as well as in the serum. We know that microRNAs seem to play a role as well in their regulation. And also SNPs were found in key players like the serotonin transporter, the type 3 receptor gene, to also impact the system and thereby making people prone to develop IBS. And most of the findings were actually found for diarrheic IBS patients. And let me close with the outlook that I think there is a huge potential for the 5-HT system to be targeted by drugs, and we already have drugs on the market, and therefore which help patients, but we do not know whom to treat with which type of drugs. And that's why I think pharmacogenetic studies are key in order to find out who might best respond, and that we also should keep in mind microRNAs, which might be useful. And with this, I'm at the end, and I thank you for your attention, and I'm also happy to take questions. Thank you very much.
Okay, so we'll leave questions for the end after Dr. Simrén speaks. I want to thank Beate. That was like a really fantastic lecture, and we're really lucky to hear from one of the world's experts on this topic, and also with the interaction of the microRNA, which I was not as familiar with. We're going to go on to our last speaker, and that's Dr. Magnus Simrén. He's professor of gastroenterology at the University of Gothenburg. He's also an adjunct professor of medicine at the University of North Carolina in Chapel Hill, and his clinical work is dedicated to the management of patients with functional GI disorders and GI motility disorders as well. He is a leader of a large clinical and translational research group with a focus on these disorders. And today, Dr. Simrén is going to talk about Rome classifications, the power of defining symptoms in the classification, diagnosis, and treatment of motility disorders. Magnus?
Thank you very much, Lin, for this kind introduction. And thank you to ANMS for inviting me to give this presentation with the title, as Lin just said, Rome-based focus on Rome classifications. So when we see patients in our outpatient clinic, they report different symptoms from different parts of the gastrointestinal tract, here shown as upper GI symptoms, but also lower GI symptoms. For the majority of these symptoms, we cannot find an identifiable cause on standard investigations. And furthermore, these patients often report symptoms from different parts of the GI tract, both from the upper and from the lower GI tract, and there is a huge overlap of these symptoms, and this overlap is also related to different healthcare outcomes in these patients. But the patients don't only report symptoms from the gastrointestinal tract. They also frequently report symptoms from outside the GI tract. They report different non-GI symptoms and syndromes. And on this slide, you see a number of non-GI symptoms or syndromes that are more commonly reported in patients with functional GI disorders than in the general population. So a classification system is obviously needed to optimize the management of these symptoms or these patients. And as you know, the Rome Foundation has offered such a classification symptoms now for several years for these disorders of gut-brain interactions, formerly known as functional gastrointestinal disorders. And in the most recent iteration of this classification, the Rome 4 classification, these disorders are defined as a group of disorders classified by gastrointestinal symptoms and related to any combination of motility disturbance, visual hypersensitivity, altered mucosal and immune function, altered gut microbiota, or altered CNS processing. And these disorders can be divided into different anatomical regions based on the presumed origin of the symptoms. As an example of this definition, I here show you the definition of the functional bowel disorders according to the Rome 4 criteria. And these disorders are defined based on a combination of various degrees of pain, abnormal bowel habits, and/or abdominal bloating and distension. And in the recent iteration of the Rome 4 classification, we also highlighted that these disorders exist on a continuum or a spectrum of these disorders, and sometimes patients move in and out of these disorders over time. Another example from the Rome 4 classification is the classification of functional dyspepsia, and as you probably all know, functional dyspepsia is defined based on the presence of at least one of the cardinal symptoms: epigastric pain, epigastric burning, early satiation, and/or postprandial fullness. And the functional dyspepsia can also be divided into two main categories, namely epigastric pain syndrome and postprandial distress syndrome. And this has bearing for instance, for the treatment, which I will come back to later on. But there are also examples in the Rome 4 classification where symptom-based criteria and biomarkers are combined, something that I think we will probably see more of in the future. The functional defecation disorders, which are defined based on the presence of either IBS with constipation or functional constipation, and at least two abnormal tests suggestive of defecation disturbance. So why shouldn't we replace symptom-based diagnostic criteria solely with biomarkers today, or even test abnormalities? Because I think many of us would find this quite useful in our clinical setting and in the discussion with our patients. And there are several reasons for this. One is the often relatively poor correlation between objective findings on special investigations and symptom severity. Here exemplified from a study showing the lack of association between gastric retention as a marker of abnormal gastric emptying and symptom severity proposed to be characteristic of gastroparesis. And also other well-established pathophysiological factors such as oral transit time, considered to be of importance for the bowel habit abnormalities in IBS, often show relatively modest associations with, in this case, bowel habit abnormalities, even though the correlation is statistically significant. It is a relatively modest or weak association. And moreover, the current view on the pathophysiology of functional gastrointestinal disorders, and on this slide, IBS, is that it is a complex and probably multifactorial pathophysiology of these DGBIs. Brain-gut interactions are of importance, hence the term disorders of gut-brain interaction. And you also see here some of the many different abnormalities, pathophysiological abnormalities that can be found in at least a subset of IBS patients. So quite a complex picture when we try to explain the symptoms to these patients. And many of these factors also frequently overlap. Here, a slide from a recent study that we published last year, where you can see the overlap among three of the key pathophysiological factors in IBS. Psychological distress, here used as a proxy for central nervous system dysfunction, visual hypersensitivity, and abnormal transit. And I think you can see that there is a clear overlap among the different pathophysiological factors. So it's difficult at this stage to define a disease based on only one abnormality. And these factors then seem to interact and cumulatively influence symptom severity. And this is again from our study where we define the presence of these different pathophysiological factors: hypersensitivity with its two key components, hyperalgesia and allodynia, transit abnormalities, and anxiety depression as a proxy for CNS dysfunction. And with increasing number of these abnormalities, we can see a gradual increase in the symptom severity and a gradual decrease in the quality of life, highlighting the interaction among these different factors. And this complex picture is not specific for IBS. Also in functional dyspepsia, there is a considerable overlap between the predominant symptom subgroups when it comes to the different pathophysiological abnormalities: delayed gastric emptying, hypersensitivity to gastric distension, impaired accommodation, and H. pylori infection. And when performing a similar exercise in functional dyspepsia, as I previously showed you in IBS, focusing on the key pathophysiologic factors, delayed gastric emptyings for solids and for liquids, gastric hypersensitivity, impaired gastric accommodation, and defining the number of subjects with these abnormalities, you can see that there is again an overlap among these factors, with several of these factors being present in a sizable proportion of the subjects. And in line with these findings in IBS, we could also demonstrate that there is a cumulative effects of these pathophysiological factors also on the symptom severity in functional dyspepsia. So with increasing number of these pathophysiological factors, we noted a clear increase in the severity of overall dyspepsia symptom, but also seen for this different specific symptoms such as early satiation, epigastric pain, and postprandial fullness. So defining these diseases based on only single abnormalities does not seem possible at the moment in the clinical setting. So the symptoms included in the symptom-based diagnostic criteria here exemplified for IBS can also be useful in the diagnostic approach for these patients and can serve as a starting point when making a diagnosis of these different disorders. This is a quite complicated scheme, but it actually highlights how you can use the thorough clinical history to make the assumption that the diagnosis is present. You can combine that with other clinical history findings such as absence of alarm symptoms and also absence of family risk for colorectal cancer, IBD for instance, and combine that with some routine laboratory tests. And if these are normal, you can make a safe diagnosis of IBS. So the starting point in this diagnostic algorithm is a careful assessment of the key symptoms making up the diagnosis. But it's important to state that making solely a symptom-based diagnosis is definitely not sufficient to determine the management of these disorders. And this has been highlighted by the Rome Foundation by proposing a multidimensional clinical profile, or an MDCP concept, where the categorical diagnosis based on the symptom-based criteria is the starting point, for instance, making a diagnosis of IBS. But this should then be combined with assessing the presence of clinical modifiers, for instance, having a specific IBS subtype, let's say IBS with diarrhea. Then combine that with the influence of these symptoms or the impact of these symptoms on the daily life, dividing it into mild, moderate, or severe. The presence of psychosocial modifiers, for instance, the presence of comorbid anxiety, and the presence or absence of different physiological abnormalities and biomarkers. And here we could add some of the actionable biomarkers proposed by Professor Camilleri recently. And combining all of these different aspects actually helps you define or determine the management of the patient. So I find this quite useful in the clinical setting. So it's very important to stress that making a categorical diagnosis is definitely not sufficient in order to determine how you manage these patients. And finally, a couple of words about treatment. Also here, the symptoms or the symptom-based diagnosis are of importance when determining the treatment that you offer to your patients. Here exemplified by functional dyspepsia, defining the two main categories, the epigastric pain syndrome and the postprandial distress symptoms, which actually influences the choice of treatments, where some of the treatments are more effective for epigastric pain, whereas others are more effective for postprandial distress syndrome, even though there are some treatment approaches that are similar across these two different main categories. And also for IBS, the management is determined based on the symptoms or the combination of symptoms defining the diagnosis and the subtypes. So you have different treatments if you have diarrhea predominance versus pain predominance, bloating or distension predominance, or constipation predominance, or whether you have an overlap of different symptoms. So also here, the symptoms or the symptom-based diagnosis is helpful when determining the treatment. So to conclude, I hope I convinced you that the Rome classification based on symptoms and in some instances also in combination with biomarkers is helpful in making the diagnosis and also to determine the optimal treatment for the patients, and also to provide information to the patients, to give the patient the name of their diagnosis, and in some instances also of importance for providing prognostic information to the patient. But it should be stressed that the symptom-based diagnostic criteria should definitely not be used in isolation, but should be used as one part of a clinical decision algorithm. And with this, I would like to thank you for your attention. I'm also happy to answer questions. Thank you.
Thank you, Magnus. That was a wonderful talk. Really appreciate that. We have some time, about 10 minutes, and we have our panel together. If you could turn on your camera. We have a few questions in the Q&A. There's one question, this is to Michael. Does response rate to bile acid sequestrants without testing depend on the clinician's assurances and how they're presenting the data to the patient? And those factors for educating the patient also corrected in studies comparing bile acid measurements to empiric treatment groups?
It's a great question. And of course, we know that there's a very large placebo response whenever we propose a treatment to any patient. So I think the conviction, and the questioner is absolutely correct in asking, does the conviction with which the physician presents the opportunity to treat the diarrhea or the bile acid sequestrant, does that conviction and education impact the outcome? And absolutely, that is a factor that needs to be involved. So I have to acknowledge that I didn't have time in this rather short presentation, but obviously that was a retrospective chart review of more than 1,000 patients at Mayo Clinic, of which about 600 had had the bile acid test and about 257 or thereabouts hadn't had the bile acid test before they were given the sequestrants. But when you just followed those patients up and you looked at the outcomes, it appeared that getting the test done was also possibly part of that education process in getting the patient to be convinced that this was an appropriate treatment. So thank you for the question. It's an absolutely important consideration.
If I can add, I think that's a great point, and I think it's important not just for bile acid sequestrants, but for all treatment that we educate our patients properly. So I think that's a key comment actually.
Yeah, I was just going to say that it applies to anything like diet, yeah. And also for side effects. I remember that with elocitron. If the physician was worried about ischemic colitis, the patient's going to be worried about ischemic colitis. So a lot of times it's how you present it, and I just try to give a balanced educational information. There's another question I'll open up to anyone. There is currently a lot of emphasis on the role of IB-Stim, which is the neurostimulator. It's FDA approved here for children with IBS or chronic abdominal pain. There's a lot of emphasis on the treatment of patients with IBS. Sometimes it's even like solo therapy. Does anyone have any thoughts on this and its place in the management of patients with IBS?
Over to you, Magnus.
I haven't used it at all, so I don't have any personal experience. It's certainly interesting, to use electrical stimulations in different parts, but I don't have any experience on my own.
Yeah, we're actually, oh, go ahead.
No, you go ahead.
Oh, I was just going to say, we actually are trying to do a pilot study in adults with IBS because it's FDA approved for children. It's a little harder in the pandemic time to get people to actually want to come in every week and place this, but you have to place it once a week for 5 days. So I mean, so you have trouble with washing your hair. And then you take it off after 5 days and then you come back the next week. So you do 4 weeks in a row. So we'll see if that really helps patients, adults at least, with, although they've studied it in 18-year-olds and so in the pediatric population. Michael, were you going to add something?
Yeah, I was going to add that, whenever we apply something to the somatic nervous system, remember the theory of Melzack and Wall, and that is that in some respects, the theory of referred pain, where you send a message up through the same pathways and you can confuse the brain from perceiving visceral pain. So I have an open mind about it, but I think it's important to do the controlled studies with appropriate sham stimulation, etc.
Yeah, agree. We have another question, but I want to ask Beate a question. So I think it's interesting in studies with chronic constipation, also the IBS-C, and you showed the IBS-C study where there's increased mucosal 5-HT content, and then the SERT, I guess, is decreased. And I was trying to, and then you also showed the transporter gene SNPs associated with IBS-C, but I'm just trying to think in my mind from a physiologic standpoint, how is increased 5-HT mucosal content, and serotonin is thought to have a prokinetic effect, less SERT, how is that causing constipation?
It's a very good question. We don't know yet. So the SNP, which was so actually this study which found decreased SERT and increased 5-HT was a study from 2004 where it was actually found in the same way decreased and 5-HT increased in both IBS-C and IBS-D. And they also didn't really have an explanation, but what we know is from the SERT knockout mice, for example, also switch. They can be either constipated or they show both types of phenotypes. And in the case of this SNP, which we found associated with IBS-C, it was actually a SNP which was protective. And the major allele, which is so-called the wild type, if that was present, it seemed like that the stools were softer. It was the other way around. So it was not a risk allele. And so far, the SERT studies are somehow contradictory. We really have to do additional studies because in our cell model, the functional readout was different compared to what we found in the tissue of the patients. And another thing which makes it really difficult is that SERT is not really robustly expressed in the large intestine, which does not make it easier. So this is a very good point, but it's really hard to answer. We need more studies there.
Yeah, I agree. So we only have a few more minutes, so I just want to go to a couple more questions. So Magnus, is Rome 5 going to change the emphasis on symptom-based diagnosis then?
Mm-hmm. I think this, I mean, we haven't even started yet, but I certainly think that the symptoms will be there, but I hope and I think that we will have more biomarkers included either as supportive elements in the diagnostic criteria or even included in the diagnostic criteria. That's what I think all of us would like to see, but we need the evidence to really include them in the diagnostic criteria. But at least category E in MDCP, they are very important, as Michael pointed out, actionable biomarkers in some patients, and we use them like that already now.
I think it'd be also important to give recommendations on how you're using those biomarkers in clinical practice too. I think that's really important.
Absolutely.
So Michael, there's a question for you. Is there any association between SIBO and, I'm not sure what IMO is, and rectal evacuation disorders? Methane excess has been associated with slow transit, but I have noticed patients with, do you guys know what IMO is?
Intestinal methane overproduction, perhaps? Maybe.
And dysynergia who undergo treatment often have improvement in not only bloating, but also in their dysynergic symptoms.
So is the question, if you treat the IMO, you get rid of the dyssynergia? Did I understand that correctly?
Yes.
Yeah, of course, I mean, we haven't actually studied that ourselves, but I do think that there are these three factors are all playing together. And that is the slow transit, the methanogenic bacteria, and the presence of dyssynergic defecation. And obviously, if you have dyssynergic defecation, you may be preserving your methanogenic bacteria in the colon, preferentially, and you may also be causing slow transit. So I think teasing this out, where you have three factors which may be co-opting each other or collaborating to produce the symptoms, I think it's going to be very difficult to tease them out. So yes, indeed, as the questioner appropriately says, this may be a factor, and as Beate mentioned, further research is necessary.
I want to ask both Michael and Magnus the last question, which is, this overlap of gastroparesis, functional dyspepsia, and using gastric emptying time. So in clinical practice for our clinicians, do you recommend that when someone comes in with symptoms that meet the criteria of both, or really gastroparesis doesn't have a criteria, but do you always order gastric emptying tests, and does that change your management?
Okay, I'll start. I do a gastric emptying test that is at least 4 hours in duration, and that assesses the emptying of solids. So with respect, Magnus, you showed the data from from Jay Pasricha, which was the 2-hour gastric emptying profile with a 2% egg Beater's meal, which we know has virtually no diagnostic capability. So the first thing to do is, if you're going to do a gastric emptying test, do the right test. The other thing that I do is, it changes my practice, Lin, when there is at least 80%, there's at least 20% to 25% retained in the stomach at 4 hours. Those are the patients that I'm really going to think are much more aligned towards the gastroparesis, and I'm going to use a prokinetic much more liberally. Magnus?
I also use it quite a lot in our specialty clinic practice, but I'm less overwhelmed with its performance in predicting treatment response. I think it's more useful in diabetic patients than in other patients with upper GI symptoms. So I tend to use it more in diabetic patients than in other patients with upper GI symptoms.
I mean, Jan Tak's group did have a study with prucalopride showing improved emptying and symptoms in gastroparesis, suggesting that a prokinetic agent would be useful in that subgroup of patients. So I do think about that. Okay,
and indeed, of the 28 patients, 26 of them were idiopathic and only 2 were diabetic. So in this overlap, as you're mentioning, it also could be beneficial. Quite.
Okay. So we are at the end of this great symposium. So thank you everyone for joining. But I want to thank the speakers, and I hope everybody learned a lot from this. I want to close with a slide that if Stephanie could put up to get, you can keep this conversation going on the ANMS Doc Matter site. So we have that here. You can see that, www.docmatter.com/ANMS. Also, this whole symposium will be on the ANMS website in 48 hours or so, and also you'll be linked to the ANMS YouTube channel. So please feel free to look at the ANMS YouTube channel for more videos and webcasts that the ANMS have done. So thank you so much, everyone. Have a good day.
Thank you.
Thank you.
Thank
Bye-bye.
you. Thank you. Goodbye.
Bye-bye.
Bye.